the X-ray. So clearly no medial joint space on either side. Lateral compartment looks all right. If you can notice the timeline here, this was X-ray done in 2014, and then the right side is 2016. She took this much time because she was not convinced yet. So she had, meanwhile, her sister had a similar surgery, HTO, and once the benefits were proven to her, then she was ready for the surgery. So the valgus stress fuse shows good opening up on the medial side. No FFT, not much of patellofemoral arthritis on the lateral X-rays. That was her gait preoperatively. Has got lateral thrust on the left side, but right side just a minimal sort of varus. Right, any varus would have it. Knee range was good. And these were the full-length X-rays showing LDFA of 92 degrees on the right side and 93 on the left side, since the right side was more painful. And at that time, we didn't have much as good those Tomofix implants for the DFO. At that time, we were using overcorrecting the tibias and compensating in the HTO. So those were the steps for the HTO: placement of the wires, proximal screw, adding the shunt screws distally, and showing the steps here because I just want to highlight few points later on for the osteotomy. So the orange cortex is the osteotomy, the posterior cortex. The green arrow is the yellow arrow is the anteromedial cortex just below the tuberosity. The green arrow pointing to the opening. See the hinge there is intact, and the osteotomy is then closed and the fixator is compressed. So post-op pictures once she started the distraction after 7 days. And once, because there was so much of JLCA, we called her earlier for the full length X-rays. And if you can notice over here, the posterolateral, this is like a type 2 hinge fracture, which is developing there, but her HK was still undercorrected. So we asked her to distract for 6 days more and then lock the fixator. These are the X-rays at 2.5 months and 3.5 months. The healing has progressed, but it's still not convincing at 3.5 months. Because she was sending X-rays from her hometown, we could not really get good X-rays and see the posterior cortex. So we continued with the fixator. The hinge break there is forming some callus. And this was her gait without the stick. So she was still lurching. She was not really confident to walk. And at this point, we decided that we should call her over and have a look and get better X-rays at least. And this was a picture when she presented at 4.5 months. The lurch was still there. There was no pain. The osteotomy is not healed fully, but on the lateral 2/3, it seems pretty good. The callus seems to have formed laterally. The hinge seems to have healed, though not fully bridging. We did a stress test. There was no pain. There was no change in the gait, but there was a collapse of 4 mm on the fixator. So we did a CT scan and found there were areas of healing, but there was area of gap, especially in the posteromedial aspect. So what was really happening here? So the orange arrow there is pointing again to that lateral hinge, which is not healed. The blue arrows is pointing to lysis in the distal pins, again, the mechanical issue, the posterior cortex has, there's no solid bridging happening there. The oblique views were also showing some lysis in the proximal, around the proximal pins in the near cortex. Those green arrows are pointing to that. So this was a mechanical issue which was going on because of the lateral hinge fracture. So the dynamic fixator, the HTO fixator has that self-aligning hinge, which will move and will have this inherent instability in that. So the plan then was to change the fixator to a LRS type of fixator with a T-clamp. There's no hinge. And for the biology, add in GNX. And since she wanted to save time, she also wanted to get the left side HTO done in the same sitting. So we went ahead with that plan. Left side HTO done. Same. This time we wanted to make sure that we have reached far enough. So the osteotomy is reaching closer to the lateral cortex this time. And then freshening of the osteotomy on the right side. Drill holes made, curettage done on the near posteromedial cortex, added in GNX, and changed the fixator to a LRS with a T-clamp. That's the left side post-op. And this is the LRS fixator with the fixed T-clamp and the GNX. Now, as luck would have it, she fractured again on the left side as well. The orange arrow is pointing to that. The HK was 183. And at 4 months, now she has fixator on both sides, though the right side, she's able to really weight bear well. Left side, not so good. She's finding it really difficult with fixators now on both sides, though the fixator on the right side is more anteromedial than the left one. That was the range with the fixators. And the right side has then, after the revision, has progressed. The healing has progressed. The lateral side has filled up well, almost to the near. Just the medial cortex needs to be bridged, and the posterior callus has now really bridged well. So at this is the usual picture which we see at 3 months in a regular HTO, and they are then ready for fixator removal. The left side, not doing so well. The healing is progressed as compared to the 2 months picture on the left side, but again, not much seen posteriorly as well. So we did a CT scan again to confirm. Right side was healed well, so fixator removal was planned. Left side was healing, but then again, there were areas of gap. So we didn't want to delay it too much this time and offered her the same surgery as the right side. But she was not ready. She was convinced that once the right side fixator is removed, she would be able to weight well better and wanted to wait for a little longer. So that's the right side after removal. And then we reviewed her again after a month. The gait has improved now, though she's just using those crutches for the balance, but she's able to weight bear better. But the X-rays show otherwise. Marginal improvement in healing, but still those areas of gap persist. Now she's started developing a little bit of mechanical lysis around the proximal pins. So this time around, we were able to convince her for changing the fixator. And the left side was revised the same way. freshening of the osteotomy, change to an LRS fixator with a T-clamp, and GNX after freshening of the osteotomy. These are the post-op pictures. And then she continued to weight bear well at 3.5 months post-revision. Almost full bridging of the osteotomy gap is seen, though the posterior one is still a little, callus is not seen as well. So again, we did a CT, because then at this point she should be really be healed, as the right side has showed. But since we have added biology, we have taken care of the mechanical instability. So we just dynamized the fixator by adding a dynaclamp onto that and continued to wet bear. And following the dynamization, then the healing has really improved a lot. And in another 3 months, she was then ready. So the comparison of the gait after the dynamization, she was really tentative initially to wet bear on the left side, but now at 6 months, she's walking pretty well, and then the fixator was removed. So the time periods for the right side were revision surgery was done at 5 months, and total fixator time was 10 months, including the initial surgery. And left side was revised at 6 months, and total fixator time was 12 months. This is X-rays at 2 years and 3 years. Right side is 3 years. So now notice that obliquity in the joint line, because we compensated for that distal femur deformity in the tibia by overcorrection. Notice the anatomy here. Even though there was a lateral hinge fracture, there's not any it's not subluxed or displaced anymore further, and she's got a good knee range. At 5 years follow-up, now she's doing all her activities without any difficulty. She started regular gymming, which she always wanted to do. In the end, she's a happy patient, but it did really take a long to get there. So just want to discuss a little on the lateral hinge fractures. Takeuchi described these 3 types. Type 1 was the extension of the osteotomy in the same line, and type 2 was the extension of the osteotomy in distally, and type 3 is 2 examples like we have seen, which extend into the lateral condyle. So the learning points here was are basically type 2 and type 3 lateral hinge fractures. They are unstable. They are prone for delayed and non-unions of the osteotomy. One should prevent the lateral hinge fracture, especially if doing it with the plate. We have discussed those points of putting in the wires. And Ogawa in 2017 described this osteotomy endpoint, where the osteotomy should be at the level of fibular head. If it's any lower or any higher, then it makes it prone for the lateral hinge fractures. They also describe this concept of sufficient osteotomy, where the anterior limb and the posterior limb of the osteotomy, where does it end? So this dotted line here is the tangential line on the tibiofibular joint. And they recommend that the osteotomy should be extending lateral to this lateral zone, and then it reduces the risk of lateral hinge fractures. Not so much, all this is CT scan findings, so really difficult to judge on table or where we are ending it. The HTO fixator in lateral hinge fracture is not stable enough because of its self-aligning hinge. So it doesn't allow any compression at the hinge fracture. So if it is it is going towards a delayed healing phase, one should change the fixator to a stiffer one with a LRS fixator and a T-clamp. It's more stable, and add biology. Bone grafts or autografts are much more beneficial. One can add bone graft substitutes as well, like we did GeneX. Now, from this case, again, earlier, like we discussed in the previous one, planning makes it important, where LDFA now, anything beyond 90 degree, we will add a DFO. Here it was 92 degrees, so it was considered borderline, but again, that increased our tibial correction, which poses you at a risk of lateral hinge fracture. So adding a DFO will reduce the amount of tibial correction, and don't sort of give in to that pressure of the patient, and don't do the other side till one is fully healed. Maybe slightly things could have been different on the left side, since she was not weight bearing well on either side. May have put added pressure on the left side, which has led to the lateral hinge fracture on the left side. And bilateral non-union, always think about some metabolic issues going on. Thank you. Thank you so much.
The main lesson I think I learned from this is the importance of the femoral osteotomy.